My name is Leanne Foster, and I am a Provider Outreach and Education Specialist here at WPS Government Health Administrators, and I'd like to welcome you to our Medicare Physicians in Residency Programs webinar. I'll start with our disclaimer. We have prepared this information with the CMS regulations as we know them today. So the material is accurate as of today, and as you know, Medicare changes often. So please be sure that you are reviewing official CMS communications, including the CMS and WPS GHA website for the most up-to-date CMS rules and regulations. I'm also going to be answering questions based on the regulations as of today. Now, moments ago, I did just start recording this session for your awareness. So photographing, screenshotting, or recording of this education for profit-making purposes is prohibited by CMS, but there's also not a need. As I said, we are recording this session, and it will be made available to you on our YouTube channel and our WPS GHA website as soon as possible after today's session. That's going to allow you to view it again if there's something you missed or wanted to see again, or share it with anyone that was not able to attend today but may find this helpful. So that brings me to our agenda for today. So today we are talking about Medicare providers in a residency program. There are a couple of different ways that Medicare will cover services that are performed by a residence, either through their training program underneath their teaching physician, or in certain circumstances, the resident will be able to bill Medicare directly. However, these services will be handled a little bit differently depending upon where they're provided and how they're impacted, or as the scope, whether or not they're related to the scope of their training program. So today we're going to be focusing on Medicare physicians in that residency status, but they're performing services outside of the scope of their training. And this will include conversations about when they can bill Medicare and what is considered a moonlighting service. And we're also going to help you understand today how to enroll to bill Medicare or to enroll to order and refer only if needed. Really depends on that provider's setup. Now, before I go any further, I do want to be clear that today we're not focusing on how to bill for services rendered by a resident when in the teaching facility. However, Ellen held an event last week, which was Medicare Teaching Physicians Guidelines, that includes some information on this. So I have asked Ellen to put the link in the chat for the YouTube. That is the encore of that session last week. If you'd like to take a look, there's a lot of good information in there that would be helpful. Also, we did receive a couple of pre-submitted questions that were related to specific billing situations. I want to thank those individuals for submitting those questions, and I just want to make you aware that you will be receiving responses to those, but they are being sent outside of this session because they're directly related to that billing. So be on the lookout for those. I want to start by defining a resident in the eyes of CMS and the Medicare program. So CMS officially defines a resident as a physician participating in an approved postgraduate training program, and physicians who are maybe not in approved programs, but they're authorized to practice in a hospital setting only. And typically that is going to be a situation where the hospital may be absorbing the cost of that resident's training program. So some examples of this are going to include residents, and this would include senior residents that are maybe working with other residents and fellows, and then also providers that are in a fellowship. They are handled the same way. Most of the time, or oftentimes when we're talking about residents, we are talking about providers that may be fully licensed to practice medicine independently outside of the scope of their training. And this is going to be the purpose of discussion today. We're going to talk about what's considered inside scope versus what's outside of scope, and those services for outside of scope are billable to Medicare, but they do need to go through an enrollment process. For the most part, that enrollment process is similar to any other provider, but we are going to call out some of the differences today. So let's walk through what services within the scope of the training program look like. So we're talking about professional services, And when they're inside the scope of a residence training program, they're generally provided within the hospital, or they could be in a non-hospital setting such as an outpatient clinic, but they are at the facility where the resident is going through their training, and they are part of the training program. They are a requirement of that training program. Typically, these are services that are going to be paid through either the direct graduate medical education program, also referred to as the DGME, or the indirect medical education program, also referred to as the IME. These are federal programs that are reimbursing or paying for or covering the cost of that training program. The other situation that may happen if it's inside scope is that the hospital may have agreed to absorb the cost, as I mentioned earlier. So they don't necessarily have to be in one of these programs to be considered within scope of their training. Then you're going to have services that are provided outside the scope of their training. So in this situation, it is possible for a resident or fellow to be participating in the DGME or IME program. However, their services are not requirements for their graduation. These are services that the provider or the resident could bill to Medicare, again, because they're unrelated to the training program. And you're going to hear me talk about that a lot today because that's really the critical piece of this. Are the services being provided inside or outside of the scope of the training program? So if it's outside of the scope, these services, again, are billable because they're outside of that scope, and they will be billing Medicare Part B directly. And in that case, they're also not going to need to utilize the GC or the GE modifier because they're providing the services independently and they're not under the supervision of their teaching physician. They're simply a provider in the Medicare program, and we'll go through that a little bit more here in a minute. For a resident to bill Medicare, they do have to be eligible. So we are talking about physicians, and they're going to need to be fully licensed. So we're talking about medical doctors. We're talking about our doctors of osteopath, a doctor of podiatry, doctor of dentistry. These are what we're looking for. Typically, it's not going to be a non-physician. That their training programs are different. Generally, they have to be through their training programs before they can bill for Medicare. With physicians, it is different. Some of the scenarios where they may be eligible to bill, first, they're moonlighting. We'll talk about that in more specifics in a few minutes, but they're moonlighting. Maybe they are working in an outpatient department at the facility where they are receiving their training. It's possible that they are providing services in an urgent care, in an emergency department. Urgent care and an emergency department are typically the more common scenarios that we see. Again, depends on the scope of their residency, depends on what they're training for, but they can provide services in urgent care and emergency situations where outside of the scope of that residency. So next we're going to look at how that resident is going to enroll to bill for Medicare Part B. There are two forms that that resident may utilize, and it just depends on whether or not they're billing for Medicare services or they're going to be ordering and referring for services being provided by providers that are going to bill for Medicare. Now, why would a resident outside of their scope not provide the services or not want to bill Medicare? It's usually because of where they're providing those services, and we'll talk about that more when we talk about the ordering and referring. I do want to start out with that application, and then we'll talk about that ordering and referring situation. I want to talk a little bit more about moonlighting. This is typically what we see, is that a provider is rendering services at a facility outside of their training facility, or they're providing services at a private clinic, an outside clinic, or just in an outpatient department. We talked about that a little bit, and it's typically an urgent care and emergency department. But again, I want to stress it depends on what that resident is training for. It's possible they could maybe be changing specialties, and it's for a regular clinic inside that facility. The key here is that it has to be unrelated to their training. So that's going to need to be the question that is asked, and we're going to have to be able to identify that it is unique to their training program and outside of that scope. There's a lot of good information on this also in the Code of Federal Regulations, and it is CFR 415.208. It's services from moonlighting residents. So enrollment requirements. The enrollment requirements for a resident, they're really not that different from a regularly enrolling provider. Again, we're talking about that resident that's not providing services inside the scope of a DGME or an IME training program, and that they are fully licensed to perform those services. We are going to ask and verify those license information or that license information. Sometimes we'll see providers that will have a temporary license. This doesn't necessarily preclude somebody from enrolling in Medicare, but it does require us to look at the restrictions on that temporary license. And so a lot of times that temporary license is so restrictive that we may not be able to enroll them. So that's something to consider as you're doing this. These enrollment requirements, the need for them to be fully licensed, that is the same requirement if your provider is billing Medicare or if they're ordering and referring only. So we're going to start with a provider that actually needs a P10 that's going to bill. They are going to submit the CMS 855 application, and they can do this in a couple of ways. They can do it either electronically through the Provider Enrollment Chain and Ownership System that is also known as PACOS, or the paper CMS 855I. My recommendation to you is that they do so electronically. And that's because the electronic version of the form is always going to be the most efficient way to enroll any provider, whether they're a resident or, again, just any provider. So the paper 855I, it is available on CMS's website. You can complete the information in the template, but then you do need to download that and mail that in to us. So there's an additional process. Obviously, there's the mailing process, and then it takes a few days for it to get scanned and fed into our workload system so that we can review that. Just to give you an idea of the difference in timeline, an electronic application that requires no development, that's going to process in 15 calendar days. A paper application can take up to 30. And again, that's if there's no development. There's just a much quicker response time for electronic applications because there's a lot of automations we can take advantage of. Plus, enrolling a provider now while they're in a residency and providing services they can bill for will set them up for post-graduation and getting enrollment numbers beyond that. Okay, so next I'm going to go through the sections of the 855I. I will be doing so using the paper form just because of the structure of the questions. However, the questions are the same. If you're doing it electronically, there's nothing different. You will be answering the questions through the residency information topic, and that is a topic that shows up on any initial enrollment. So whether your provider is a resident or not, it's going to be that same process of setting up that application. The first section that I want to highlight of the 855I is section 2F, and this is specific to a resident. This is asking questions about their residency program. This is required for all providers that are in an active training program. This will include situations where they are enrolling to bill for services with an effective date that is after their graduation date. Oftentimes what we'll see is the application will get submitted prior to their completion date or their graduation date. And that is okay, but because at the time of submission, they are actively in a residency program, they still need to complete this section. So to step through this, it's going to ask for the name of the hospital or facility where they are completing the residency. It's going to ask for the facility's street address, and it has to be a street address. It cannot be a P.O. box. And then the top red box, what you'll see is the question asking if the services rendered at the facility that you just listed in Section 2F are part of the requirements for graduation from a formal residency question. Yes or no question. If it's not, we know as a MAC we're typically going to be falling into some type of a moonlighting situation. More often than not, the answer to this is yes, but again, it depends on your residency program and the provider that you're enrolling. If you answer yes to this, the next thing we're going to ask is the date of completion. As I said, it's not uncommon for residents to have their enrollment application sent in prior to graduation. So the day after graduation, they're good to go. They have their provider transaction access number or PTAN so that they can bill Medicare right away. We do look at this, and if the effective date that they're requesting on their application is after that graduation date, this serves as informational for us anyway. We do capture that information, but we can also say, yep, they were in a residency program, but they didn't ask for the PTAN until after they were complete. The next question is going to be about whether or not the resident is also rendering services at other facilities or practice locations. Again, this helps us identify a moonlighting situation. So again, it's a yes or no question, and if yes, it's telling you you need to complete sections 4B and 4F. Now, more oftentimes than not, the section that we see these addresses completed in are going to be in section 4F. 4B is going to be for a resident who maybe is going out on their own right away and they're in a private practice. They're not reassigning benefits. They're not working for any facility. That is a much less common scenario. I won't tell you that it doesn't happen, but it is much less common. As I said, more oftentimes than not, what we see is a resident's graduating and then they're reassigning to a facility. Sometimes it's the facility they received their training from. But this section is telling you then make sure you fill those out as well. You won't get a PTAN without that. The next question that you're going to see is the bottom red box, and they're asking if the services that you render in any of the practice locations that you reported in 4B or 4F part of requirements for your graduation from your residency. We're asking the same question a couple of different ways, and we know that, and that's intentional. Again, we're making sure that we're not reimbursing for services that are already being reimbursed through another program, and we're making sure that the provider has either graduated or is truly moonlighting and these services are outside of that scope. The next section I want to talk about is section 2D. Now, this is not unique to residents. It is the provider specialty section. It is something that must be reported. Simple enough, but sometimes it can get a little confusing, especially if you have a provider that is able to practice in, maybe they're general medicine, but they're in a residency program for cardiology. We want to make sure that the specialty here is the specialty that they are practicing in when providing services that are outside of the scope of their residency. You don't want to report the specialty that they are still in a residency for. Okay. You will also notice there's a section here for undefined specialty. That is one if the providers do not fall into one of the categories, they can write in a specialty. However, typically, this is something that may not be approved. The list of specialties for physicians on the CMS 855I is complete, and these are the valid specialties that CMS recognizes. Sometimes what we see is that they'll maybe have missed their specialty and they wrote that in. If we find that, we can continue to process the application. But if it's truly an outlier, it may preclude the provider from enrolling at least with that specialty. And what it'll do first is it'll trigger development to clarify what specialty the provider needs to be enrolled in. So the next section is section 4F, and this is the final section that I'm going to be highlighting on the 855I today. So this is the section where the provider is going to reassign benefits. Late summer last year, CMS consolidated the CMS 855I, and some of you may remember the CMS 855R. The 855R information that was previously a separate application is now incorporated into the 855I with section 4F. So it's really important that this gets completed so that we know where the resident is reassigning their benefits, if they are reassigning benefits. And again, that is the most common situation that we see. So the blue arrow is pointing to the section that is asking for the resident's information. Obviously, we're going to need their name, we're going to ask for their social security number, and we are going to ask for their employer's tax ID. The Medicare ID number, so the PTAN field, your resident may not have a PTAN, and that is okay. If they don't have it, you can write pending, or you can leave this blank. If the provider does not have an existing PTAN for themselves practicing outside of residency, they can certainly put that here. The NPI, so that National Provider Identifier, you do want to make sure though that your residents have applied and received an NPI. Again, we're talking about enrolling residents that are fully licensed, that can practice outside of the scope of their residency, so they should have an NPI if they're going to be billing Medicare. We cannot enroll them without that NPI. That's the same as it is for any provider outside of residency. So make sure that they have that. If they don't, that will cause delays because we will develop that and that application will not process until we have that. And we want to avoid that. The green arrow, that is pointing to the organization or the group that's receiving those reassigned benefits. So we're obviously going to need their name, their tax ID, their Medicare ID or PTAN, and their NPI. Keeping in mind, this could be the facility where the resident is receiving their training program, but again, it's for services outside of the requirements of that residency. And I'll always come back to it's typically urgent cares and emergency room departments. Sometimes it's other outpatient departments, but again, depends on that resident's situation. The image on the right, that's that yellow arrow that's pointing to the section. This is an optional section. This is a section that's asking for the primary and the secondary location for the provider. So it's going to be something that you can provide us. It does populate a directory of sorts that Medicare beneficiaries have access to. What I want to make very clear here, though, is listing the practice locations here does not impact whether or not the provider can get paid for that particular practice location. If the location they're practicing at is part of the group that they list in question 2 of section 4F, which is that green arrow, if that location is listed on that group, that resident is going to be able to provide services there. But again, we're not looking at them so much as a resident at this point because we're talking about services they're providing outside of their scope. So I'm going to move on to situations where you have a resident, they're providing services, but they don't intend to bill them to Medicare because they're working in a situation that is likely, examples include like VA hospital, they're working for a VA hospital, they're working for something with involving TRICARE, they're maybe working for a public health agency. Basically, they are not going to enroll in Medicare because, again, like with their residency training program, they're involved in a program that's going to reimburse at 100%, so they're not billing. However, they may need to refer a patient outside of that facility for services they cannot provide. When those services are billed by the providers that can offer those services, we are going to need the ordering or referring provider's MPI on the claim. That MPI does need to be in our PACO system because that PACO system is feeding the claim system. And if that MPI for that ordering referring provider is not in the claim system, when that claim comes through, it's going to cause denials. And again, we want to avoid that. So they will complete an 855-0. Again, they can do so either electronically or through a paper form. Again, I'm always going to argue for that paper form. It's more efficient. It'll set you up better for PACOS 2.0 down the road as well. They still have to be licensed. They still have to meet all of the qualifications as if they were going to bill for Medicare. However, the main difference here is they're not going to be billed Medicare, obviously. They're also not going to be assigned a PTAN. They're going to be completing kind of an abbreviated 855I. If you've ever compared the 855I and the 855O application, the O is really just a kind of a stripped down version of that. A lot of similar information is requested, but a lot less of it. The other thing is at the end of the processing of a CMS 855O, we're not assigning a PTAN. The provider will be notified that their MPI is now in the claim system so they can order and refer, but they're not getting a PTAN because they're not going to be able to bill. And again, this is for services that are being provided outside of that scope of that residency, but they're not going to be able to bill Medicare. So there's a couple of sections I want to focus on here as well. So section 2B of that 855-0 is going to be the reason for submission. This is one place that this is definitely going to differ from that 855I. You'll see my red box there. It's saying that you have a licensed resident that's not employed by an entity in Group 1. If they're employed by those, group entities, their billing is going to be a little bit different. But if they're not employed, but they know they're not billing, they still need that MPI in the system, that's the box that they're going to select. And this would be the same selection when you get into PACOS. It'll be streamlined because it'll ask the questions slightly differently, but it will ask those same questions. So they will indicate that. That's telling us that this is a resident. We don't start asking the questions on the 855-0 about graduation, about other locations, because again, they're not billing Medicare for services. Then again, we're going to see the specialty section. On the 855-0, that is going to be section 4A. And the same thing here is that they're going to need to select their physician specialty for a resident. What you're seeing here, you will see some eligible non-physicians. That is not specific to residency. That is specific to ordering and referring. So just bear that in mind. Again, we want them to select the specialty that they're ordering and referring services under, and it could be different. They may have multiple. So before we get into questions, I do want to point out some resources that I've made available to you in the materials for today. There is a WPS article on physicians in residency programs. It goes through the different methods of enrolling a provider. It will talk about when a resident can actually bill. And then also there are some CMS references. There is the Medicare Learning Network article that will talk about teaching physicians along with residents. So it'll kind of a good one-stop shop for all of this information. I've also included some references to the Program Integrity Manual for Enrollment. It'll talk about that residency section, and then also the Medicare Benefit Policy Manual for any billing questions that you may have. So with that, I'm going to check in with Ellen. Do we have any questions in the chat?
Yes, Leanne. Our first question says, does this information apply to a federally qualified health center clinic that has a family practice residency program?
It does. And again, it comes down to whether or not services are being provided inside the scope of the residency program or not. The regulations are not different for billing those services.
Okay. Then our next question, it says, how can we be certain who we should reassign benefits to? For example, we have a residency program through our facility, but the residents are coming from a university.
Good question. So if you have a residency program through your facility, but the residents are coming from a university, and I'm assuming, and please, if I'm missing something, please throw that in the chat. But if they're coming from a university, they're coming from another facility, it just depends which facility is the requirement for the residency program. Now, you have a residency program through your facility. When they're providing services as part of that, which is a requirement of graduation, that's going to fall under the same guidelines as you'd be billing through that hospital. It'll be part of that teaching physician situation because it's part of that residency program. Those aren't going to be billed to Medicare. But if you have services that are being provided by those residency, again, such as an urgent care, those are going to be outside of scope. And even though they're coming to you for a residency program, they may also be providing services that aren't related to that residency program. Those services could be billed to Medicare, just not the ones related to the residency.
Okay, thank you, Leanne. The next question that we have is, would you repeat the information you provided on the Group 1 selection regarding Group 2, the licensed resident not employed by any entity in Group 1?
Yep, let me go back to that slide. Oh, sorry, scrolled too far. All right, so in section 2B, there's Group 1 and Group 2. So if they are a resident and they are employed by any of the facilities in Group 1, that's one of the reasons that they would be enrolling to order and refer only. So if they're employed by VA, public health, IHS, they're already being reimbursed for services through a different federal program. And so they're not going to be able to double dip, if you will. So that's Group 1. Still a resident, but employed by one of these. Group 2 is you have a licensed resident who is not going to be billing. They're only going to be set up to order and refer, but they are not employed by any of the entities listed in Group 1. It just depends on their scenario. And there are different reasons why a resident may not be billing Medicare for services outside of their residency. Some of them purely are just ordering and referring. Any other questions?
Yes, hang on a second. I got to get back to the top of it. Okay, so this question says, our family practice residents are providing services in our FQHC for family practice specialty. Therefore, the services get billed under the teaching physician with the appropriate modifier per the guidance from CMS. Is that correct? Are the residents required to enroll with Medicare?
So you are correct. Because the services that they're providing are billed under the teaching physician, that is going to be billed with that appropriate modifier per that guidance. That is correct. In that instance, those services are inside of scope and they would not enroll in Medicare to bill for services because they're being billed under the teaching physician guidance.
So the first question then, is that for diagnostic services as well to Medicare Part B under the teaching physician?
It would be any services that are inside the scope of that residency program.
Okay. And then the next question that we had is, how does the service qualify for billing under a teaching physician within specialty or services only qualify due to the primary care rule. So what Leanne has been talking about here today are resident services that are outside of their residency training program. So if you have residents who are providing services under the teaching physician, and there are two sets of guidelines for that, teaching physician guidelines and then the primary care exception, you're not going to be enrolling your residents in order to bill for Medicare. You'll bill under your teaching physician along with the appropriate modifiers. And that holds true for both under the teaching physician and under the primary care exception rule. Does the teaching physician have to be present during the session with the resident? And do you care if I respond to that one?
If you would like to, that is fine.
Okay. Under the teaching physician guidelines, there are two rules, teaching physician and then primary care exception. If you're billing under the teaching physician guidelines, yes, the teaching physician does have to be present, does have to be present with that resident during the key and critical portions of whatever service you're billing for. Under the primary care exception, and this is for evaluation and management services, low-level E&M services, and the annual wellness visit, the teaching physician does not have to be present, but there are guidelines that go along with that where the teaching physician and the resident are interacting either during or directly after that resident's encounter with the patient. And I have placed in the chat the YouTube location for the teaching physician guidelines that we did just last week. Thank you, Leanne.
Thank you, Ellen. That will end the presentation for today. I do want to thank everyone on behalf of Ellen, myself, and the entire GHA Provider Outreach and Education team. I appreciate you taking the time to attend today. We look forward to those survey comments. And again, please remember to provide any suggestions that you have for future topics. Thank you, and I hope you all have a great day. You may now disconnect.